So first, I would like to thank Dr. Jagnany for giving me opportunity to present here. Today, I am going to brief about the assessment of pulmonary artery pressure by echocardiography. Basically, pulmonary hypertension is characterized. It is a pathological hemodynamic condition defined as increase in mean pulmonary artery pressure of equal to or more than 25 mmHg at rest or more than 30 mmHg during exercise. Right heart catheterization is the gold standard method for the assessment of pulmonary artery pressure till now. Pulmonary hypertension could be a complication of cardiac or pulmonary or primary disorder of the small pulmonary arteries. Transthoracic echocardiography can be used to investigate and quantify the pulmonary artery pressure, as well as it can also assess the contribution of left ventricular systolic and diastolic dysfunction, valve function, and congenital lesion to the etiology of the pulmonary hypertension. Elevated pulmonary pressure measured by echocardiography associated with the increased mortality irrespective of etiology. While though the transthoracic imaging is not the gold standard for the assessment of pulmonary artery pressure, but it is readily available bedside technique accepted as the primary non-invasive tool in the assessment of pulmonary artery pressure. Now I'm going to present the common technique that we currently use in our day-to-day practice for the assessment of pulmonary artery pressure. Their advantage, disadvantage, pitfalls. These are the common methods that we commonly use. That is pulmonary artery pressure by peak PR velocity, mean pulmonary artery pressure by PR Doppler signal, PADP by PR in velocity, mean pulmonary artery pressure from RVOT acceleration time, mean pulmonary artery pressure for TR velocity time integral, RV free wall strain, that is systolic cardiac velocity and velocity time integral, right ventricular isovolemic relaxation time, TI index, that is myocardial performance index of RV, and TR measure PSP, pulmonary vascular resistance, and pulmonary artery pressure measured when during exercise. Now I'm going to detail that most of our colleagues are using it in their daily practices. The pulmonary artery pressure assessment, systolic pressure by peak PR velocity. We use the simplified Bernoulli's equation to assess the pressure, that is 4V square. How we do it? We have to see the various echo views in which we get the maximal TRZ, like either maybe RV inflow view, parasternal short axis view, or a apical 4-chamber view, and put the continuous wave Doppler on the TRZ and identify the best Doppler signal. And we have to measure the peak TR velocity, and the time machine will automatically calculate the peak PA pressure. In that we have to add right atrial pressure, and we can get the pulmonary artery pressure. The things that has to be taken care of, we should get the full Doppler signal for the proper assessment of the pulmonary artery pressure. If the your Doppler signal is not adequate, like you can see in these images, you can underestimate the pulmonary artery systolic pressure. The TR velocity of less than 2.8 millimeter per second is normally considered normal. What are the points to be taken care of? The lesser degree of TR occur in compensated RV because of elevated right ventricular pressure. This can lead to underestimation of pulmonary artery systolic pressure. Similarly, severe TR may lead to equalization of RA and RV pressure, leads to cut short the Doppler signal and resulting underestimation of the pulmonary artery pressure. So we have to take care of all these things. By we have to see the all 2D cine loops and assess the all the things. And mean pulmonary artery pressure can be assessed by this pulmonary artery systolic pressure by using formula 0.61 multiplied by systolic peak arterial pressure plus 2 mmHg. The good Doppler envelope is main prerequisite for this method. In case of one thing should be taken care of, that in presence of RVOT obstruction like pulmonary stenosis, this method may lead to falsely elevated pulmonary artery systolic pressure. In that case, we have to subtract the peak RVOT gradient from the pulmonary artery systolic pressure. That will give you actual PESP. Now the second method, mean pulmonary artery pressure by peak Doppler, peak PR Doppler signal. Mean PAP is calculated from the 4V square of the peak velocity plus right atrial pressure, and multiple views to be taken to obtain the good Doppler signal. And in case of weaker Doppler signal, we can use the agitated saline. In presence of constrictive physiology, this method will be not accurate. Now, the pulmonary artery diastolic pressure can be calculated from the pulmonary artery diastolic velocity. We have to measure this diastolic velocity multiplied by 4 plus we have to add right atrial pressure. How we can use the right atrial pressure? Hello. Right atrial pressure can be assessed by the assessment of the IVC. We have to see the IVC dimension and the respiratory collapsibility. I'm in the top. Hello, am I audible? Hello. Hello.
Yes, ma'am, you are audible.
Okay. So I was talking about how to assess pulmonary artery diastolic pressure. Am I audible, ma'am?
Yes, ma'am, you are clearly audible. You can go ahead.
Okay. Okay. So how we have to assess the right atrial pressure? We have to see the IVC dimension and the respiratory collapsibility. Normally we take the cutoff 2.1 centimeter of IVC, and it should be more than 50% collapsible during deep inspiration. If it is like this, we commonly take the value of 3 to 5 mmHg. If the IVC is dilated more than 2.1 centimeter and there is less than 50% respiratory collapsibility, we take RA pressure approximately 15 mmHg. Mean PAP can be also calculated from this method, that is 2/3 of PADP plus 1/3 of pulmonary artery systolic pressure. The limitation is the same as constrictive or restrictive physiology will cut short the Doppler signal and we can not accurately assess the PA pressures. Mean of several measurements to be done to achieve the adequate number. Mean pulmonary artery pressure assessment by RVOT acceleration time. Pulse wave signal is to be put on short axis just proximal to the pulmonary valve. That is in great vessel view. measurement taken to peak velocity. We have to trace from the peak velocity to the onset of the signal. More than 130 milliseconds considered to be normal. Less than 100 milliseconds is suggestive of pulmonary hypertension. And we can roughly assess the mean pulmonary artery pressure by using this formula. That is mean PAP equal to 90 minus 0.62 multiplied by RVOT acceleration time. Mid-systolic notching in the outflow signal also suggestive of pulmonary hypertension. Now, RV free wall strain, tricuspid annular systolic myocardial velocity, and with velocity time integral also helps to assess the pulmonary hypertension, but it is a qualitative test. We cannot quantify the exact PA pressures, but it is indirect evidence that give the hint there is elevated pulmonary artery pressure. If tricuspid annular systolic myocardial velocity is less than 12 centimeter per second and velocity time integral is less than 2.5, it is suggestive of pulmonary hypertension. We have to use the narrow sector width to maximize the frame rate and appropriate signals. Now, right ventricular acceleration time can also use to assess the pulmonary hypertension. How we can do this? We have to switch on the TDI and put the pulse wave Doppler on the lateral tricuspid annulus. At the recording should be done at the sweep speed of 100 milliseconds, and the time is measured from the offset of F wave to the onset of E prime. If it is more than 75 milliseconds, it is suggestive of pulmonary hypertension. If it is less than 40 milliseconds, it has very high negative predictive value. That means patient chances of pulmonary hypertension is very less. The limitation of this method is in presence of RVB, HCM, and RV dysfunction that may cause the increased RVOT relaxation time. This method is not reliable for assessing pulmonary hypertension. In case of tachycardia, rate corrected IVRT should be done. That is RVIRT divided by underscore RR interval in ECG. We can also assess the pulmonary vascular resistance by echocardiography by using peak TR velocity. That is peak TR peak tricuspid velocity in meter per second divided by RVOT VTI in centimeter multiplied by 10 plus 0.16. Increased pulmonary vascular resistance is suggestive of pulmonary vascular pathology. TI index or myocardial performance index is also TDI based imaging. We can calculate the TI index by calculating IVRT divided by IVCT plus ejection time. Normal value is 0.28 plus minus 0.04. If TR velocity, PA pressure is more than 35 mmHg measured by TR peak velocity and TI index is more than 36, it is suggestive of pulmonary hypertension. While assessing and measuring all these parameters, we should also look in the 2D imaging for all these findings that also give indirect evidence of pulmonary hypertension. Like if we see the RVH and dilatation, RE dilatation, and decreased deceleration time of early mitral inflow, it gives indirect clue for RV pressure overload. Systolic flattening of the IVS or D-shaped LV with reduced diastolic and systolic volume with preserved systolic function also indicate RV pressure load. Pulmonary sinus dilatation, IVC dilatation, hepatic vein dilatation with reduced severity of the IVC suggestive of elevated RA pressure. Pericardial effusion is there basically due to the impaired lymphatic drainage secondary to elevated RV pressure. That also indicate there may be chances of pulmonary hypertension. Last TR is due to RV enlargement and tethering of leaflet towards the apex. Increased tie index because of RV dysfunction. So basically, echocardiography is easily, readily available bedside techniques to diagnose pulmonary hypertension. And scoring system can be derived from the combining various echocardiographic derived measurements of PAP along with exercise testing to accurately identify an assessment of progression of pulmonary hypertension in patient and minimize the need of invasive assessment. Thank you.
Thank you so